So after the tea break, we are going to start the next lecture, and will be presented by Dr. Gary Mack. I think probably there's no need for any introduction because everybody knows Dr. Mack. He is, as a cardiologist, but also has a great interest in sports medicine, and is currently the president of the Hong Kong Association of Sports Medicine and Sports Science, and is also the consultant cardiologist of the Hong Kong Sports Institute in the last 15 years. And Dr. Mack is, I think, is a man with vision and mission, and he probably sees the needs of developing sports evaluation, especially in the field of sports cardiology in Hong Kong, which is not yet well developed at this point. And he also did a lot of, make a tremendous effort in promoting the awareness of pre-participant screening, especially in the field of cardiology, for doctors in all for Hong Kong, and also for individuals who would participate in different kinds of sports. And actually, Dr. Mack also has a lot of other experts in cardiology. He's, apart from an interventional cardiologist, has also a lot of expertise in CT. He is also one of the pioneers in introducing the CT's cardiac CT in Hong Kong, and also a fellow of the Society of Cardiac CT. So this topic, I think, without further delay, I would like to invite Dr. Gary Mack to talk about the pre-participation cardiac evaluation, the role of cardiac CTA. Dr. Mack, please.
Thank you very much, Chairman. Thank you, Donald. It gives me great pleasure to welcome you all to this symposium. I will take the next 15 minutes to talk about the role of CT scan in the pre-participant physical evaluation. Before that, I want to welcome you all as a president of Hong Kong Association of Sports Medicine and Sports Science that was developed or founded by Professor K.M. Chan about 27 years ago, and which we invite you to go to our website and register as a member. And as discussed by Dr. Lee earlier on, the cause of sudden cardiac death actually is age-related phenomenon, and those who are younger than 30 years of age, the cause of sudden cardiac death is mainly structural and familial disease like cardiomyopathy and channelopathy. For those older than 35, they're mainly deemed to coronary artery disease. So according to the ESC criteria, the evaluation of younger athletes go for physical history and ECG. However, from the older athletes, because the commonest cause of sudden cardiac death are due to blockage in the coronary artery, and therefore, and many of them do have major coronary risk factors. So the focus is very different from the younger athletes. Basically, for the guideline, we want to assess what kind of physical activity they are engaging in. For those engaging in moderate to high intensity exercise, we want to assess the risk factor, and most of the time we use the coronary risk score, and sometimes we do exercise stress tests. As far as the coronary risk score is concerned, it is quite sensitive and specific for those who have high coronary risk. However, for those with moderate or intermediate risk, actually the sensitivity and specificity is actually not high. And therefore, it comes to the concept of plaque burden assessment. We want to know exactly how much plaque there is in the body, and that will give us a much better assessment of coronary risk. And since the introduction of low radiation CT scan in 2005, and it has evolved greatly in the last 10 years, and we have been using it as an option to assess athletes of the older age group. What do we mean by low radiation coronary cardiac CTA? Basically, an average individual exposed to the environmental radiation, and the background radiation is about 3 millisieverts. Low radiation CT scan, we talk about sub-millisieverts radiation CT. And basically, with the later model of dual source, like Siemens force, we can get a very good image of cardiac CT scan with only 0.4 to 0.6 millisieverts, which is less than 1/3 of our annual radiation exposure. And this is one of the examples. You see that very high quality image resolution. You can see through the coronary stent with a very high resolution. And the CT scan was performed without breath hold, and the radiation exposure is only about 0.4 millisieverts, which is much, much less than the background radiation. The beauty of coronary CTA is that it's very, very high negative predictive value. That means that if you have high quality coronary artery images with a completely normal coronary artery, practically you rule out coronary artery disease, and the patient is very safe to engage in high intensity competitive sports. In others, we do see plaques. These are the morphology of different plaques. You have a calcified plaque appear with very bright signal. You have a non-calcified plaque appear with dark shadows, and you have mixed plaque. The degree of plaque burden gives us a very good prognostic predictive value through the different systematic review and meta-analysis. For those who have no plaque or no CAD, the incidence of any major cardiac event, death, MI, or revascularization is practically zero. That's the meaning of the negative predictive value. For those moderate or non-obstructive coronary artery disease, the incidence, the risk increases. However, for the obstructive coronary artery disease, they have a very high risk of future events. So the plaque burden gives us a very reliable assessment of the coronary risk. This is one of my patients a few years ago, a 45-year-old man, high competitive Asian Game athlete, regular training, exercise, 25 to 30 hours per week, totally asymptomatic, come to me with severe hypertension, severe IVH, and the CT scan showed blockage of the right coronary, severe stenosis, LAD, and a blockage of the left coronary, left circumflex artery. In fact, regular endurance training increases our endurance, and many of them are actually very symptomatic. David had mentioned about the use of ultrasound, echocardiogram to identify the ostium of the coronary artery and make the diagnosis of coronary abnormality. And for those who cannot be seen with echocardiogram, and cardiac CT scan is basically the gold standard to make a diagnosis of coronary anomaly. This is another patient who presented with me with a 35-year-old man, presented with me with collapse and arrest during jogging, and he was resuscitated from recurrent VF. And when we did the CT scan, he had a normal coronary artery. However, the cause of the coronary artery actually is abnormal. When we see coronary artery, we call it epicardial coronary artery. That means the coronary artery runs on the surface of the left ventricle. However, this gentleman has his LAD dive very deep in the muscle of the anterior wall of the left ventricle. During diastole is a good flow across into the myocardium, of the coronary artery, and therefore a myocardium. During systole, this coronary artery actually completely obliterated, and that's the reason why he had exercise-induced ventricular fibrillation. This we call it myocardial bridging. The deeper the bridging and the longer the course of the vessel inside the muscle, the higher the risk. We have another patient, 45-year-old man, present to me with chest tightness and syncope after running up 10 flights of stairs. We thought it's probably most likely coronary artery disease. We do a CT scan. His coronary artery is totally normal. There was no aortic dissection. However, there's a major thrombus in the pulmonary artery from the right side to the left side, and in fact, he has a recent history of long-distance flight. And when he's run upstairs with a high force to the blood clot actually come from the deep vein developed in his calf, and after extreme exercise and movement of the lower limb, the blood clot went up to the pulmonary artery and causing pulmonary embolism. So it's something we do pick up on the CT scan because we do see the pulmonary artery in a regular acquisition. Some people think that coronary artery CT scan looking at the morphology itself, but in fact, the development of coronary CT has progressed to a stage you can actually look at function. This is a man with a blockage of the LAD in the proximal segment, and we can do a CT scan of the blood perfusion showing the hypoperfusion in black over the anterior wall and septal wall, and this is severe ischemia over the anterior septal region, and this finding is consistent with the SPECT imaging. And for those who are interventional cardiologists, that means who do balloon angioplasty, who open up the artery with balloon, feel that sometimes it might be more reliable to do a functional flow reserve by looking at the flow reserve across the coronary artery to identify whether this coronary artery need to be dealt with, need to be opened up. And in general, if the coronary flow reserve or less than 0.85 is we said to be acceptable. Less than 0.85 is severe, need to be treated. For more than 0.75 is abnormal. This patient with proximal LAD lesion, CT FFR, so 0.62, which is consistent to the invasive FSR of 0.65. So this patient needs intervention. This patient with right coronary artery stenosis, CT FFR, so 0.87, and corresponding invasive FFR from 86. So this patient do not need intervention. Coronary CTA actually sometimes has added value in this case because we have information about the wall septum, about the LV dimension, and this patient has obviously severe hypertrophic cardiomyopathy of the septum. So sometimes this kind of data we do not charge them extra. So there's no extra cost. And we can also look at the heart valve. We pick up a bicuspid aortic valve from a CT scan as well. So to sum up, actually, CT scan at this stage, we consider it's a non-invasive, all-in-one technology. It can simultaneously give us an anatomical and functional assessment. So I think it would be a very useful alternative for assessment of athletes older than 35. Thank you very much.